Thanks, Dr. Flores, and thanks to Linda and the ADO for inviting me. Can I have my first slide? Is there a pointer or nothing? Yeah, there it is. Okay, today I'm going to talk about surgery in mesothelioma, and that's been something that has been varied over the years. I do have one disclosure. That I'm a scientific advisor for the Pacific Heart, Lung, and Blood Institute. My talk is going to be about two different areas. One is going to be the surgical procedure that we use, and this has been really a tale of two procedures: in extrapleural pneumonectomy, which removes the lung plus tumor around it, and then the pleurectomy decortication, which removes only the tumor. I'm also going to talk about a second area, which is an opportunity for people to use surgery as an opportunity to put in additional treatments during surgery, into the chest. So I'm going to talk about that as well. This goes back to the 1980s. This is Harvey Pass's data from the 1980s showing in the upper slide here, this is survival of patients over time. And you see better survival with the less tumor that was left after surgery. So if you remove more tumor, people survive longer. And this has been kind of the basis for looking at surgery in this disease. And we fast forward to just a few years ago, then there was a trial called the MARS trial, the Mesothelioma and Radical Surgery trial. This was done in the UK, and this is a feasibility trial, which is only to look and see if people could be randomized to having surgery or no surgery. And they had a number of issues with it, but this is the data that came out of it, and this is not a conclusive data, it's only a feasibility trial. But the interesting thing was that everybody expected that extrapleural pneumonectomy, which was the surgery used in this trial, would be better than doing nothing. But in the top survival graph right here, this is doing nothing, and actually surgery had less of an effect than doing nothing. So there has been a number of conclusions from this, although you can't really conclude anything because it's, again, only a feasibility trial. But it certainly gave no indication that taking out the lung was beneficial. And actually, this is the quality of life data here, and this shows that in the red, this is the surgery again, the quality of life is lower than without surgery, and that's particularly right after surgery, that's obvious, but during the whole period it was also less. So this was also with taking out an extrapleural pneumonectomy, taking out the lung. This was not with a pleurectomy, which is the other operation. So after this, a lot of the world stopped doing surgery altogether and doing extrapleural pneumonectomies because it didn't seem like there was a lot of benefit to it. There's a lot of critique that was leveled on this, and first the pathology data was not included. There was no pathologic stage. Chemotherapy was not standardized, and only about a third of them got the standard pemetrexed or Alimta and cisplatin combination. There's also a lot of crossover, so patients who were randomized to get chemotherapy only or supportive care actually went and got surgery outside the trial and vice versa. And there was a lot of dropout. So if you look at the total number of patients they were trying to admit to the trial, only 16% of them got to the randomization. So this didn't apply to the majority of patients. And there were a couple of other minor critiques. So basically, this was shot down by a lot of people who are enthusiasts for EPP, but I think there is significant information we can take away from this. So the other thing that's been going on over the last number of years is kind of the argument of whether you should take out the lung or not. And you do EPP versus pleurectomy, and there have been a couple of meta-analyses, one by Dr. Flores, and this is the other one. And I thought I'd show you, which is basically looking at all the data in the literature and trying to analyze it with some fancy statistics to see which one of the two treatments would be better, since there is no direct comparison or randomized trial. And so what this shows, if you look over here, this is the data that comes out of this. It looks at a number of different trials looking at both of these. And what they do is they put a line down the middle, and they analyze the statistics, and anything to the right of that line, or sorry, the left of the line for you, and the right, over the right to the line here is beneficial for taking out the lung, or EPP, and this to the left of the line is beneficial for pleurectomy decortication. And this is looking at just postoperative complications. And we've all known that taking out the lung has more complications, so this was not a surprise, but all the lines, all the little dots here come down on the left side of the line. So this all favored doing a pleurectomy, not an extrapleural pneumonectomy. And this was very statistically significant. And then it looked at also the chance of dying after these operations. And again, everything came down pretty much on the left side of the line, which is favoring plerectomy decortication and not extrapleural pneumonectomy, and this is also statistically significant. So with this, a number of centers who've been doing doing extrapleural pneumonectomy have now switched to doing actually pleurectomies. So in summary about this, there's been no proven benefit to doing an extrapleural pneumonectomy, taking out the lung. Certainly, this was shown by the Mars trial, as well as 2 meta-analysis, both Dr. Flores and this other one. At this point, all we can really say, we conclude that if you're going to do surgery, plerectomy decortication should probably be the surgery. Now I want to switch really quickly to the intraoperative potential therapies, because when you operate on somebody with mesothelioma, you have the opportunity to have the whole tumor bed open to you, so you can actually do additional therapies to try and extend what surgery can do by itself. And there are a number of different things that you can do, including chemotherapy with or without heat. You can look at thermal therapies, just heating or cooling by itself. You can look at chemical therapies like betadine therapy, some people are looking at light therapy, photodynamic therapy, and a few other immunotherapies, which I think are the most exciting but are least developed. So if you look at intrapleural chemotherapy, one of the issues is that there's a number of problems with the chemotherapy. There's a low response rate in general. It's only a single dose, and we know that chemotherapy works best if you give multiple doses in multiple cycles. It's shown that there's actually significant absorption. It's almost essentially the same as giving an intravenous dose, because a lot of it's absorbed from the large surface area, and you usually need multiple drugs. Most of the time, people in the past have only given a single drug because of the worry of toxicity. And there's been no randomized controlled trial, so there really is no good data to say whether you should use this or not. This is some data from about the 1980s. It's from a laboratory that I actually worked in doing hyperthermia research, and this looked at a number of different tumors they took out of people directly. These are all the different tumors, and this is the survival of the tumor in Petri dishes and treated with heat for a longer period of time. So the longer you treat it, it goes to the right. This is at 45 degrees, which is a very high dose not used in humans. But one of the tumors that they happened to treat was just one tumor of mesothelioma. And in the red here, you can see the survival. So mesothelioma appeared to be a heat-sensitive tumor, and this kind of led to a lot of what people thought might be beneficial of combining chemotherapy with heat. And there's also some other data that suggested that chemotherapy with heat allows chemotherapy to get into the cells faster. So this is some data that ultimately fast forward again to the HIAC experience. This was a presentation that was given to one of the surgical meetings and published a couple of years ago, I think, which showed a series of patients treated with what we called HIAC, or heated intraoperative chemotherapy, versus not. And this, again, was not a randomized trial, so you can't conclude really anything definitively. But there were a number of patients that were put on this trial. One of the key things, there was no randomization. And the decision to treat with HIAC or not was basically, quote-unquote, determined on an individual basis, which meant they chose people based on reasons that they did not or could not explain. And basically, what the problem with this is that there was 2 groups that were not actually balanced. There were a number of things that were not balanced in the 2 groups, so it certainly is not something that I think we can conclude from this. The paper that was published concludes that there's benefit to doing heated intraoperative chemotherapy, but there was so many differences between the groups, you really can't say that for sure. And again, there's no randomized trials. And this was with a single chemotherapy drug too, just cisplatin. So there's variables that go into all this, like what kind of chemotherapy agents to use, the dose, time, how much you leave it in there, and temperature, which is very important as it turns out. Can't go into that in more detail, but we looked at this very extensively. When all this talk was going on, we had decided to go to the laboratory and see if this was really beneficial and really try to determine if there's going to be any benefit to doing this and what actually the conditions should be. So in Petri dishes, we looked at a number of different cell lines. This is a little kind of busy slide, but I'm going to give you kind of a summary here. So this is a normal lung fibroblast line. This is a lung cancer line, and all these 3 things are mesothelioma cell lines. And so what we did is we heated these with pemetrexed and cisplatin, so this is including all, and we heated it for a longer period of time. So each one is being heated for a longer period of time at 41 degrees, which is clinically what a lot of people were using, 41 to 42 degrees. And what you can kind of conclude from this is that this is the red line here, is the effect of heat. So there is very minimal effect of heat at all for the entire period of 60 minutes. And there was an effective chemotherapy, which we know about. Pemetrexed and cisplatin does kill mesothelioma, and so there was a chemotherapy effect, but there essentially was no effect. And putting the two together, there was a very minimal effect of adding heat to chemotherapy. So we concluded that there really is not a lot of data at these temperatures that it can be effective. Now, if you go to 45 degrees, which is a lot hotter and that nobody's been using in humans, you can get a little bit more effective adding heat to chemotherapy. However, we kind of discovered doing similar types of trials that looking at cold actually is quite different. So if you look at cold down to 4 degrees, it doesn't really do much. In fact, it preserves cells. But if you look at freezing cells, it's actually an interesting effect. And over here, this is a CT scan, so it's like looking from your feet towards your head. So the left side of the body is on your right, and the right side's on the left. The spine is back here, and this is the breastbone. I can barely see it, but this is an area of a patient who's had surgical treatment and had a tumor come back right beside the kidney here. The kidney's right here, spleen and liver is here. So here's a very difficult area to treat of a local recurrence after a mesothelioma surgery resection. And this is a PET scan, which lights up yellow. Wherever there's tumor, this is a CT scan that correlates with that. In the middle, what we did is we put a needle in there and we froze the tumor tissue. It goes through 3 cycles of freezing. It takes only about 30 minutes or so, and the patient goes home in 4 hours. It's an outpatient surgery, outpatient procedure with almost no side effects. And if you look at later, you come back in 3 months and 6 months, this whole thing now is dead. So there's no tumor residual. So if you freeze a tumor, you get an incredible response. And that's something that we're exploring more for intraoperative use at this point. This is some data from Joe Friedberg, who is looking at light therapy, and this is basically giving a patient some drug that sensitizes their body to light. And during the surgery, you can see on the picture on the left here, he throws a bunch of called intralipid, or it looks like a milky substance, into the chest, and he shines a laser light, and it shines very brightly. It can kill cells. And here's his survival curves. Again, this is not randomized, and there's some problems with this. You become very sensitive to light, so on a beautiful day like today in Washington, D.C., you would not be able to go outside because your skin and other tissues would be too sensitive for a number of months after you do this. So you have to avoid light. But you can see that this is the overall survival of this patient population he's treating, and there's actually a pretty good median survival compared to a lot of them is between 24 and 30 months, which is pretty impressive. But again, these are very selected patients. However, Joe is planning a randomized trial, which you have to really salute him for trying to do and to try to show whether it's actually working. So there's some other therapies, immunotherapies, which is an IL-4 toxin. We're working on that, as well as dendritic cell therapy. And but those I don't have time to go into. Those are very, very exciting. We're looking at some mesenchymal stem cell therapies that we can add intraoperatively, delivering a variety of different drugs and that kind of thing. So immunotherapy, things like interferon. And so I think that there's really a lot of optimism for this kind of treatment in the future. But to summarize everything we know now, that from what I've been talking about, that surgery, if you're going to use it, should be a pleurectomy decortication and not taking out the lung. I think that's pretty widely accepted at this point. And that intraoperative therapies do have a lot of promise. I think they've been under-evaluated, under-explored in the past. And there's certain of these that actually look like they work well. Certainly the last one is that randomized trials are desperately needed to actually show whether these things that we're trying are actually using or not. Thank you very much.